I'm Toni Esselin.
And I'm Amy Bernard.
And we are here to help make it make sense.
This is the podcast that takes complicated science and breaks it down into easy to understand language.
So buckle up, buttercups. You are in for a bumpy ride.
Record on this computer. Ooh, we are recording. Hello, everyone. We're back.
Hello, we are back for more fun explanations.
Yeah, so Dr. Toni, tell us what we're starting with today.
Oh, well, I am happy to report that our podcast is getting some reach, and we have our first negative review. And what I wanted to share is that, like, of course, at first you're like, oh no, but one of the things that, Dr. Amy and I have wanted has been like some critical feedback, like where, tell us where we're not doing well, tell us where we're doing well, tell us what needs improvement. But this review was just, no vaccine is safe. And something about being disgusted with our indoctrination. And I think that we welcome criticism, obviously, right? And everybody has their opinions. And as I've said multiple times in this podcast, this is not for those folks who have just decided that this is not for them. And there's nothing that you can do to help convince. This is for those folks who are genuinely confused. But to say that no vaccine is safe, no, like with an absolute, isn't actually true either. Because there are no absolutes, right? There are no absolutes, and so no vaccine is safe. I would tell our listeners, to go back to the podcast where we taught you to say, based on what? Based on what is no vaccine safe? Like, what is that based on? Yep. And so again, I think the good news is that we're reaching other folks. Our podcast is getting some traction, so that's cool.
That is cool.
That's very cool. But we really want to understand and like invite conversation about those folks who are genuinely, if you're saying no vaccine is safe, where's that coming from?
Right.
Like, share, where's that coming from? Where is that? What is the evidence behind you saying that, right? Like, and if everybody has their own experience, and we're never going to shake that away from anybody. Everybody has their own experience, but we want to have a conversation, and there are so many particularities in the work in medicine and in science. There's so many things that are specific, and there's no 100%.
Right.
There's
absolutely. And the other piece to that is, different people have different responses to the same medicine, whether it's a vaccine or Benadryl or ibuprofen, Tylenol, all these different things. Like, you're going to have different responses. Like, I know some people who with Benadryl, which is an antihistamine for allergies. Some people that makes them super tired, others not at all. I've even heard one person that's like, oh, that keeps me awake, which I was like, I have never heard. Oh, you, okay.
That's probably for me. Everybody used to use it for like insomnia.
Yeah.
And so I tried, because I'm an insomniac, and I tried it, and I was like, woohoo! Was bouncing off a wall.
Okay. So interesting, because I didn't remember that was you, because most people, it's like, I don't know, 95% or something, it makes them tired. For me, it does not make me tired or alert. But for you, like, so different people have different, biochemistry, and they're going to process things differently. So like, right. Toni might only want to take Benadryl first thing in the morning and not ever think about taking it at night. Whereas for me, it doesn't matter, but like, so I'm just trying to say, different people will respond differently to medications no matter what. But I'm going to show you all. Our podcast was at a perfect 5.0 from all 6. We had 6 reviews, which I know is not a lot, but at perfect 5s, even one person said my favorite podcast. I don't know. Is that our mothers? Maybe.
I think it's my
Actually,
sister.
I don't think so. But anyways, my point is, to give us a 1 and say no vaccine is safe. I agree with Tony. I would prefer that person decide to try to have a conversation. Like, we're here to answer questions. We are scientists, and Tony, scientist and physician. Our lives for the last 20 plus years and longer have been dedicated to this. We have read everything. We have learned most things. I mean, we are living, breathing immunology, public health. Like, this is what we do. To say that no vaccine is safe and then not try to, give us any context or questions is not fair. I don't know what that person does for a living, but I wouldn't say, if they've devoted 25 years to their craft, that they didn't know what they were talking about. Like, that's not something that I would do. I would say, well, maybe I don't understand how a car works in particular, if you happen to be a car mechanic, but I wouldn't say, oh, well, the way that you talk about the braking system is clearly false, and I think it works this way. Or if the person is an interior decorator, or, I wouldn't push back on, I would never use plaid. Plaid is horrible. Like,
Well, different strokes for different folks, but
exactly.
we're fighting conversation. Like, we want to understand if you truly are interested in understanding our perspective, we are truly interested in understanding your perspective. And so we have email addresses. You can leave comments. You can send those emails and detail some questions. Tell us that we didn't address X, Y, and Z, and we'll be happy to do it. And we'll be the first to be like, okay, our bad if we explain something incorrectly, or if there's something that we missed. There's a vast literature out there, and maybe there is something that we've missed, but one article doesn't mean proof either.
Yeah. So, and also an article maybe from not a reputable source too.
Right. So it just depends. Like, we're happy to dissect any information and make sure that it makes sense. And if we've missed something, let us know what we've missed, and we'll dig into it. Okay. So that was just wanted to start the show with yay, we're reaching other folks, and there's not always roses, but that's okay. We want to get better. We want to get better.
This vaccine advocacy path has not been all filled with roses. I've seen numerous pushback along the way. But there's one other thing I did want to tell people, and I promise it will be the only time I do it.
Oh no.
It's coming.
It's coming.
Here's my Band-Aid. And I don't know if you guys can see this. For those of you that are out there just listening, it is a boring Band-Aid, but I have drawn a B cell on my Band-Aid. It's an Immune Ninja Band-Aid, which I have trademarked. So I got, last time we did our podcast, I got my flu shot. Just yesterday, I got the bivalent COVID vaccine. So the vaccine that has the old version of the vaccine components, and now the newer Omicron specific. So my immune system is currently training. We know that the mRNA in those vaccines only lasts about 24 hours. So I'm 24 hours out. So it's probably stopped. If the production of mRNA is probably shutting down, just like a Snapchat message, it is now gone 24 hours later. But now my immune system's got something to do. It's going to be busy all week.
That's her way of saying she's a little tired.
A little bit, but it's not too bad. It's not too bad. And for a Minnesotan, not too bad means that's pretty good.
Oh, that's okay. All right. Amazing. Oh my gosh. All right, let's dig in. Dig in. We're going to talk today about the childhood vaccinations and their schedules, and some questions that we have. I'll tell you a couple that I get as a pediatrician all the time. But we'll get into that a little bit later. And then also to just remind folks that this season is a little tough, because we are having we are experiencing infections from 3 viruses now. We are experiencing them from flu, which we talked about last episode. We are experiencing them from COVID, which we've dedicated an entire season about, and RSV, which is another virus that we're gonna ahead and talk about that we don't have a vaccine for, but is something that is sending our children to the hospital, pediatric hospitals. I don't know how it is out there in Colorado, but in New York, it's like there are a lot of press releases about hospitals being overwhelmed, and ERs being full with a lot of children with respiratory viruses, mostly because, you know, we were shut down for, again, a good 2 years, and a lot of kids have not seen these viruses. And so there's just more for these viruses to infect. So this is what's going on.
Yeah, the Children's Hospital here in Colorado, I think, is pretty full. I mean, there's a lot of respiratory illness right now. Some kids with, you know, there's COVID going around, flu and RSV, and some kids, RSV seems to be the most prevalent right now.
Yeah.
Some kids are having more than one.
Yeah. Yeah, that's frequent. I've seen that a lot. There are a lot of multiple viruses. If you do a viral panel on a child who's sick, you'll see very often, you'll see 1, 2, 3 viruses simultaneously. Those kids are pretty sick. But we wanted to go through that with you, some of the questions that we have. And then do you want to, I can do respiratory signs and symptoms for you to look out for your kiddos. Yeah. Either before or after. You let, which way do you want to do it?
I don't know. Do you want to do, so we're going to have 2 kind of bigger topics. We're going to do RSV as one, and then we're going to slice and dice and do childhood immunization panel. I think maybe it would make the most sense to start with RSV, and maybe you start with like clinical signs and symptoms, so people even know what to look for, and then we can kind of talk a little bit about what it is and how you might treat it. Does that sound okay?
Yeah, that's fine. I'll cut this part out of the
sure.
podcast. Okay, so we're going to start this conversation with respiratory signs and symptoms first. So that you can get used to what is it that you're looking for in your littles, right? Specifically your infants, because your older children, sometimes they're a little bit more communicative about how they're feeling, but infants are not. And so for an infant, children under the age of a year, for the most part, you have to look to see their breathing patterns. And so one of the things that we look for is when you're seeing respiratory distress, which is difficulty breathing in an infant, a lot of the times they demonstrate that not only by how fast they're breathing, right? So one way is the rate at which they're breathing. How fast are they going? Normally for infants, they can breathe up to 40 times a minute, and it's okay, right? They're not in distress. That's like their normal breathing rate. And over the years, you know, as the child gets older, that number comes down. That number comes down. And so usually about a year, if they're breathing at around 20, 30 times a minute, you're like, all right. You're looking at anything else. Are they happy? Are they smiling? Is everything okay? You're trying to just assess whether or not they look like they're struggling. And so the signs of struggling. So one thing is the rate at which they're breathing. If they're breathing way too fast. So anybody breathing at one breath a second is too fast for anybody for the most part, right? So you're looking at the rate, and then you're also looking at their face. You're looking at their face and you're looking at their body. And in the face, I usually start with the nose. I look at the nose of an infant. And if the nose is flaring, you ever seen a mad child or a mad human when they're mad and their nose?
No, never. No, not at all.
So when that's happening in an infant who you're like, okay, I know you're not mad about anything, right? Like what are you doing, right? Are you mad that you have gas? Like what's the issue? But you're seeing the nose or the nostrils basically flare out. They're going out and in, out and in. Normal breathing doesn't require that. they're struggling if their nostrils are flaring. So that's usually one thing that I look for when I'm assessing a baby for respiratory distress is the nose flaring, going out and in, out and in. The other thing that I like to look for is tugging. So you look at the neck muscles, and you're looking to see in the neck if you see that there's the skin is almost kind of being sucked into the muscle. That is telling you that they're struggling. So they're like this. Well, you can't see, but for those of you on our YouTube channel, you'll be able to see. But if you want to check it out, you could look at your neck in the mirror and go, just pull up all the air, and you'll see all of your skin kind of go into your muscles. That's what you're looking for in a child, to see if they're in respiratory distress. When they're doing that means they're struggling. Okay. And mind you, I haven't even talked about sounds yet. I don't even go to the sounds yet. I'm looking at the child first. This is just my way of doing it. Obviously, if there are sounds coming out, that's going to help me decide if that sound is coming from the throat, and if the throat clogging up. So that's something called stridor, which is you hear like it sounds like that. You don't have to look. It's that's coming from the throat. And then there's wheezing, which is coming from the lungs. And then if that sounds more like a balloon that's being deflated, if you will. Now, when you're looking at, those are the sounds that I'm actually looking for. So snot and congestion sounds, that doesn't faze us for the most part. We're like, yeah, congestion. But we're looking for stridor, which is going to tell us that the child is in distress, or we're listening for sounds that are coming from the lungs, right? Which can sound like a balloon that's being deflated. And then you look at the chest. So I'm looking at the neck. I'm looking to see if muscles are tugging up here. And then I'm looking at the chest to see if the same thing is happening in the chest. And a lot of the times you look at under the ribs, that's where the diaphragm is, right? So you look under the ribs and you're trying to see if you see that sucking motion that's happening under the ribs. Now with happy babies, you can see them when they're going like this, and they're happy, and they're yay, 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 and they're having their little like happy little bicycling in the air. Sometimes you'll see that, but they're not in distress because they're looking at you smiling, right? Like they're fine. But when you're seeing that in a child that doesn't look great, not sleeping well, and they're not looking like they're having a good time, and their rate of breathing is elevated. So it's a lot of those things. It's like they're breathing a little bit faster than normal. And, I'm starting to see tugging over here, and their nostrils are flaring. That's a child that's in respiratory distress, that's struggling to breathe, and they need an intervention. Either they need an albuterol treatment, which is the medication a lot of people use in these infants, but sometimes, and for like RSV, it doesn't work. It's not really helpful. And they might need to go to the hospital and get some oxygen on board, and some monitoring, right? So those are the signs of respiratory distress. In the older kids, they have a lot of the same symptoms, right? So they'll cough. Coughing obviously is something that you can see in an infant as well. So there's the cough. Older kids get the cough as well. And everything that I talked about, the nasal flaring, the tugging in the neck, the tugging in the belly, you'll see all of that also in an older child. And sometimes what you really don't want to see, and where you need to call 911, is like you start to see like color changes. So the lips start to get blue or gray. That's something that they're not having enough oxygen on board, and you want to make sure that you're calling 911 or getting them to the hospital as soon as possible. And so, yeah, those are the signs of respiratory distress in an infant, and children are, like I said, are relatively the same. With asthma, children who are wheezing, any child those kids are the ones that are really at risk for respiratory distress when they're having infections with these viruses that we're going to talk about today, especially like with RSV. And the danger sign is when they stop wheezing. Like if you don't hear any wheezing at all, that means their lungs are not opening and they're not even trying. So hopefully that they're not in your house and that's happening, right? Like you want to make sure that they're not in your house and then you hear silence, because that's actually much scarier. I mean, usually that's happening when they're in the hospital and they're really sick. And we're trying to get medications in them, and their lungs are just not opening up. And there are other treatments for that. We can give things by the IV so that they can get their lungs opened up when that happens. But these are the things to be concerned about and to look out for if you're trying to figure out how can I tell if my child is in respiratory distress? You can tell by those signs. And also, if you're a parent and you don't like it, that's enough. That's really, you don't even have to go through all of that. If you are concerned, you know your child best. And so if you're looking at them and you're like, I don't like what I'm seeing, get them evaluated as soon as possible. You'll never go wrong. You'll never go wrong.
Yeah, those are all good, I think, bits of advice, especially for kids that can't tell you that they don't feel well. Because obviously infants, you got to be very aware of what they're looking like and how they're acting. To really kind of tell if you should take them in. And I agree with Tony. I think that, if you just feel like you want them to be seen, just have them be seen.
Absolutely.
It's better to do that than to, kind of hang out at home for, several hours and kind of, worried that they're not doing well. Just bring them in, urgent care or emergency, or if you can get an appointment with your pediatrician kind of urgently, if you can do it right away, sometimes that works too.
Right. And don't shy away from televisits. If you are only seen by a televisit, we can see respiratory distress. We can see it, and then we can direct you from there if you're unable to leave your house or anything like that. But if you're really, really scared and you really don't like what you're seeing, don't waste time. Don't waste time. Respiratory illnesses can decompensate relatively quickly. So
think about it. You need oxygen for your brain to work and your organs to work. So if you're not breathing, you're not getting oxygen to all the things you need to live. So
that's right.
Important.
All right, go ahead and dig into all the things RSV, my friend.
So respiratory syncytial virus, or RSV. So that's what RSV stands for. For those nerds out there, this is an RNA virus. So the instructions or genetic code for this virus is RNA. Remember that, so SARS-CoV-2, which causes COVID-19, that's also an RNA virus. This one's a little bit different. It's called the negative sense strand, but we don't really care about those details here, but it's still an RNA virus. For most people that would get this disease, it would most likely be mild, and those would be people that are not infants or don't have other comorbidities or other disease complications or other things that like chronic medical conditions. So most people that get RSV would have mild illness and would recover in a week or two, and it might be like a cold, it could be a mild cold, it could be a pretty nasty cold, but most people would get over that pretty quickly. But like I said, infants and young children, as well as maybe older adults and maybe adults with chronic medical conditions, are going to be the people that we need to be concerned about. And we're seeing RSV right now. It's interesting. It seems like RSV is being seen at a little bit higher rate than we would expect. It seems like, hospitals, like children's hospitals, are filling up with kiddos that are RSV positive. I think we don't exactly understand why that's happening, but it's a possibility that because a lot of us, over the last 2 years or so, have been very careful and have not been exposed to all these things, that this is being seen as something kind of new to a lot of kids and also to adults. So we think that maybe that's the reason why we're seeing it a little bit more at a little bit more higher rates than we normally would. Again, we don't exactly know why. These are just, some reasons that we think that could be true. One thing that we like to talk about in this podcast are vaccines. One of our favorite things, actually, this is what it's kind of founded on. There is no vaccine for RSV right now. I do know that there have been vaccine biologists and scientists that have been working on a vaccine for RSV for a while. It just has not yet come to fruition. I think that there has been a little bit of challenge with making the vaccine for RSV. However, I think people are still working on it. We're hoping to have something like that in the future. The reason why we make vaccines for things are for pathogens or infectious diseases that could cause serious harm, long-term consequences, injury, and or death. And RSV, like we said, it's not, for most people, it will be mild, but for infants, it can be deadly serious. It can cause some long-term serious consequences and harm. So it's a reason why I think that we should consider, having a vaccine for it, and people have been working on it. If your kiddo does have RSV, and I'm going to ask for Dr. Tony to chime in. Like I said, we don't have a vaccine, but there is a therapeutic. And this is it's a immunotherapeutic, so it's something that works with or harnesses the immune system, and it's actually an antibody. So we know all about how the B cells in our immune system, they get revved up from vaccines and they produce antibody that give us protection. So with this particular medicine is where antibodies were made by scientists that specifically will kind of bind and block, like work against the RSV, the virus, as the target. And this is an injection that some kids could get. So I know that I have twins, and they were born early, so they were premature. So they were born a couple weeks before their due date. And when they were about, I think 8 months or so, we had RSV injection, or sorry, not RSV. We had injections of this therapeutic that it has two names, and I'll give them to you, but they are, obviously jargony formal names, but it's palovizumab. And then it's also called Synagis. These are like, one of them is kind of like, the palovizumab is like the science nerd name, and Synagis is like the company name. But either way, this is an injection of antibodies. And my kiddos were given, I think, a couple of doses that was timed, a couple weeks or a month or so apart, right before RSV season, which would be, the winter. So because they were born early, and for those of you out there that don't know this, when preemies are born, the best development of your lungs occurs in mom during pregnancy. And if the lungs are still developing at the very end, and if you cut out a couple of weeks by your baby being born early, which I of course had no say in, they just came. The lungs of your baby just don't develop as thoroughly or as well. So they can still continue to develop outside the womb, but it's not as good as being inside the oven, the oven of the mom's body. So they still, their lungs, we were worried that they would maybe not respond well to RSV if they were to encounter it. So they had this Synagis injection a couple of times, and that really, we think, helped them, combat that particular RSV pathogen. So we think it worked pretty well. They did not come down with RSV. And we were very thankful that we got that, but it's also because they were under 2 years old, they were preemie. So I know that this is only given in certain instances. So I'm gonna pass the torch to Dr. Tony as far as like, when would you give that? And I guess the question is this available to everyone, or who could be eligible for this?
Yeah, great questions. I think that for the most part, I've never seen it. I've only seen, my personal experience has been in the hospital with preemies for the most part, or children that have underdeveloped lungs who are eligible for getting this particular medication. Yeah, I mean, not everybody is eligible for getting it after a certain time. You're not eligible to get it. There's really nothing more than that.
Yeah. I just wasn't sure if like,
yeah, I don't have anything more than
do
that.
you, yeah, okay. Yeah, so we got ours because our kids were preemie, like 4 or 5 weeks preemie. And you know, with RSV or RSV season kind of coming around, that was something that we were given as an option. So obviously we said yes, please. And they came to our house a couple of times, and that they were injected, and you know, as far as I know, it worked pretty well because they did not ever come down with RSV that we know of.
Right.
And I was at that time also wondering, like, why isn't there a vaccine for this?
Yeah, what's the deal? I was going to ask you. So I have two questions to ask you. One is, what is the difficulty in creating a vaccine?
To be honest, I actually don't know. I've kind of looked it up a little bit. All I've been finding is that there have been some people that have looked, you know, I wonder if it's because, and you know, I'm just kind of speculating, but I wonder if it's because we do have that that injection that works very well for, like, you know, preemies and infants that have you know, certain conditions. If it's because we have a therapeutic that could be used, and that in most cases, you know, adults and, you know, just I think across the spectrum, most people, it's a mild illness. So maybe, you know, maybe it's because of there is something that's already effective that can be given. Although I will tell you, you know, as far as like an equity issue, like, is that something that everybody could have? I mean, I know our insurance covered it because they were preemie, but I don't,
Yeah,
you know, I don't think that that's probably something that would, you know, if that was out of pocket, that would be really expensive. So, you know, I don't know.
yeah. So I can give a little bit more about Synagis, but before I do that, the other question I had for you was, if this is an RNA virus, is it changing like COVID?
You know, I honestly, I haven't read that it's changing in the same way. I think that I don't think that's the difficulty for the vaccine. I don't think it's because it's changing. It's an RNA virus, but it's a slightly different type of RNA virus. There are positive sense and negative sense, which for this podcast, that's too much molecular biology. But I think that this type of RNA virus is a little bit less likely to change. It doesn't change as readily. So I don't think it's because of, you know, mutations to this virus. Does it mutate? Likely, but maybe not to the same extent. But I haven't read that was the issue at all.
Okay.
Yeah.
And then to just to clarify the Synagis indications. So one thing that I should explain is that when your child is born premature, depending on how premature that they are, some of those kids actually have persistent lung disease as they grow. And they require oxygen. And those kids are prophylactically, or like by, you know, to protect them from getting sick, are given they're already eligible because they already have lungs and they have chronic lung disease. Basically, it's because they were born premature. Now they have developed a chronic lung disease. And so most children under the age of 2, if they have chronic lung disease, can be eligible for getting Synagis. I think that other cases or other children with other illnesses, for the risk, it's kind of a risk-benefit ratio that folks do to kind of see, should we give this, you know, if you're 3 years old and you've really got bad lungs, maybe perhaps you'd still qualify, right, for getting that getting that medication. And so, yeah, that's basically it. Most children immunocompetent, meaning that there's no reason that your immune system is weakened by any reason. Folks are not usually given. unless there's something in the history of the child that is making the pediatrician or the parent concerned enough to try to give them that medication. So that's where that is.
Awesome. And then this is so funny. I remember when there was a traveling nurse that came to our house to give the Synagis. And I have twins. I have a boy and a girl. And my son was just like the most serious little baby. We were like, he always has this little serious expression. And when the traveling nurse came, I remember she was giving him the shot, and afterwards she was kind of like playing with him, and he was laughing so hard at this nurse. It was the first time ever. And I was like, we have to come back all the time. This is the most serious little baby. I was like, we could not believe he, how like for the first time when your baby like has this like wholehearted, like they just can't stop laughing kind of thing. And it's so cute. So I will always remember the nurse who gave him a shot then was like his first ever like just belly laugh experience. Like he couldn't stop laughing. And I was just like, I was happy.
What was in that shot? And you were also like, oh, how dare you?
I know. I'm like, oh, you come to my house one time? I'm here every day. No, and she was the same one, came back, I think, the next time. And I don't know. He just loved her. It was really cute. But so I have very positive memories from that experience. But the one last thing I wanted to say about RSV is that we all know how it spread.
Oh, is it
freshly coughed pocket air, respiratory droplets, sneezes, coughed pockets of air? You get it all from walking into a pocket. And also because there's droplets, and droplets can hang out on surfaces. Yep.
You can also get it by contact. So it's not only that, but it's actually the droplets that you're inhaling.
Yeah.
But like it's that, and then also like it's contact precaution, right? So it's basically like that's why masks may not actually prevent RSV infection, because if you're touching RSV and then you're wearing a mask, so it's about hand washing with that one. It's about hand washing and trying to keep out of the pockets of freshly coughed air.
And sneezes. If you've ever seen a picture of a sneeze, if you haven't ever seen a picture of a sneeze, highly recommend you look it up. It's insane. You will never think the same way being near a sneeze.
It'll be like Dr. Tony and Dr. Amy talked about freshly coughed pocket of air. Like this is it. Like this is it. Like this.
The sneeze just spews. But also the contact thing. So like, even if you're wearing a mask, if you touch things with your hand and then,
rub your nose
under your mask or your eye, or you eat something without washing your hands, like then you've breached the barrier.
It's a wrap.
Yeah. So, all right. Anything else about RSV?
Nope.
Okay, cool. I think we got it. If any questions come our way, I think, we'd be happy to add anything, but overall we thought you should know, what is the deal with RSV since we're seeing it so much.
Yep. Sounds good.
Awesome. Can we take a quick break?
Break it up.
My daughter is having she needs me to, she sends emails to teachers for like requests for college applications, and she's freaking out that she wants me to review it because she wants to send it like now.
Okay, no problem. We'll do that.
So can we take
10
minutes? Yes. Is that okay?
From me.
Okay. Awesome. I'm going to stop the recording. We can cut this off, and then I'll just do a new one for the next one.
That sounds good.